Welcome to the ICU Management and Practice DigiConf on 20 lessons from 2020. Critical care experts will discuss the most important lessons learned in 2020, share their personal experiences, and highlight areas of improvement. The moderator of this DigiConf is Editor-in-Chief Professor Jean-Louis Vincent, Belgium. Panelists are Professor Ashish K. Khanna, United States, Dr. Audrey De Jong, France, Dr. Yasser Arab, France, Professor Vitaly Harasovich, United States, Dr. Andrzej Mikkelsen, Germany, and Professor Samir Javert, France. Let us welcome the moderator of today's DigiConf, Professor Jean-Louis Vincent.
Hello. Good to see you all. And we are looking forward to good discussions about 20 lessons from 2020. Yes, indeed. And the people we will hear and discuss with have written several papers, but they contributed to the latest issue of ICU Management and Practice. So the idea is that every speaker will start with a few minutes of thoughts about what we learned in 2020. And then we will have a general discussion with the audience, and you will be all able to write questions, either general questions or questions directed towards each of the speakers. And this is quite informal. I don't think we will project many slides. It's more a good discussion about this, and it's important. And I had the pleasure to write the first article of this issue with Nicole Jeffermans on what we learned in general and from COVID-19 in particular. I'm not sure we will focus only on COVID-19. We'll speak about 2020 in general. And the first person to intervene is our good friend Ashish Khanna. Will, I believe, focus on perioperative monitoring and what we learned to try to avoid complications in surgical patients. So, Ashish, the floor is yours. If you want to introduce yourself in just a few words, please go ahead so that we know exactly who you are.
Thank you, Jean-Louis, and hello, colleagues and everyone. So I come to you from North Carolina in the United States of America. I am an anesthesiologist and intensivist. I'm an associate professor of anesthesiology and chief for research here at the Wake Forest University School of Medicine. And a personal area of interest for me has been perioperative outcomes research, specifically focusing on the value of early detection of cardiorespiratory compromise, both within and outside the ICU. And really jumping into what we've learned last year, in fact, I will say that some of what we've learned last year is some of what we knew from before. So we knew that hypotension is common, both intraoperatively and postoperatively. We knew that exposure to hypotension increases the risk of asymptomatic myocardial injury, which in and of itself has very poor prognosis for our patients. We also know that we don't do a great job with monitoring our patients once they leave the operating room, the post-anesthesia care unit, and the ICU. They go to the hospital general care ward, and someone checks on them every once in a while, whereas they're hypotensive, they're having all kinds of respiratory depression events, and we're not checking in on them. So what has changed, or what should change, in my opinion, is our approach. Our approach should be proactive and should be predictive rather than reactive to events. We should not allow events to happen. We should predict events in advance, and we should be able to intervene to prevent events from happening. So what we wrote in ICU Management Practice was essentially the work of my own work and work of some of our colleagues, specifically looking at, first of all, the hypotension prediction index, which was developed across various centers all over the world. I know that the Dutch group, led by some of my colleagues in the Netherlands, Bart Geertz and others, did trials on the hypotension prediction index in non-cardiac surgery and found great outcomes. Some of the group at Cleveland Clinic have done trials of the hypotension prediction index. I think it's really, really valuable. It helps us predict hypotension at least 10 to 15 minutes in advance and hopefully intervene appropriately. Vasopressor, inotrope, fluid, we know how to intervene and prevent hypotension. I think the next step for the hypotension prediction index is outside the operating room, specifically in the critical care environment. That is going to be the real challenge for the hypotension prediction index.
Very good. Yeah.
I very quickly, I also wrote about the lack of monitoring outside the ICU. So we did some work where we put all of our hospital floor patients on continuous respiratory monitoring, continuous oximetry, heart rate, capnography, respiratory rate. And we found that up to half of our patients have asymptomatic disturbances in terms of hypoxemia and hypoventilation, especially those who are given opioids. And we developed something called the Prodigy Risk Score, which is a risk prediction score for those who are likely to get into trouble on the hospital general care floor. The hope is that someday everyone is going to be continuously monitored with portable, smart monitoring outside the ICU. So we can prevent ICU readmissions. We can prevent code blues. And that is really going to make a difference in outcomes. We're already doing a great job within the ICU. We need to take care of, all of these places outside the ICU that send patients back to us. So that's in short for what I've done and what I want to talk to you about.
That's great. Very important indeed, how to be proactive and how to act before the crisis, trying to prevent it, of course. And you started with the hypotension, but you rightly indicated that there are several variables that would be important. It's not only the blood pressure, but there are a number of things we can measure. And we will go back to that in the discussion, if you agree, Ashish. I will continue the rounds of short presentations with Audrey de Jong from Montpellier. Audrey, can you introduce yourself very shortly and tell us what you would like to focus on?
Yes, of course. Thank you very much for the invitation. I work in the south of France, in Montpellier, in the team of Professor Jabert, and I am an associate professor in anesthesiology and intensive care. And my focus was video laryngoscopy in general and during the COVID-19 pandemic. Indeed, my personal experience during this pandemic is that we have very hypoxemic patients and very complicated patients to intubate because they have a very strong desaturation, very rapid, and maybe even more rapid than other ICU patients. So all what we learned during the past 20 years to improve the safety of intubation procedure was very important to apply in practice for COVID-19 patients. So we had the methods of pre-oxygenation with optimal pre-oxygenation of the hypoxemic patients using pressure support to improve the functional residual capacity, and then the tools to decrease the rate of difficult intubation, increasing the first attempt of intubation. Because if we succeed at the first attempt of intubation, we then will have less hypoxemia and less desaturation during intubation procedure. That was in the current issue of ICU management. We focused on the role of video laryngoscopy, and we think it's a very important tool to increase first attempt success, but only in expert hands. And thanks to, if we can say, to the COVID-19 pandemic, we were very trained to use more and more video laryngoscopy. And so it was an even more useful tool for all the people trained, and there is more and more people trained to use it. And I think that if we compare before and during the COVID-19 pandemic, the intubation procedure is now more safe with less complication, but of course we need more data for this in the future. And one area of improvement also in the future is not only the tool, but all what is around the intubation procedure and the preparation with the use of vasopressive drugs, for example, maybe very early, maybe in with patient with low blood pressure, not only this patient, but only patient with normal blood pressure before intubation, because we know that more they are hypoxemic, more they are going after to experience low blood pressure and all the related complications as cardiac arrest, for example. So
some people would like to study it and indeed to see whether a norepinephrine, noradrenaline infusion started prior to endotracheal intubation could decrease the complication rate. Yeah. Did you see did you participate perhaps in the Intube study, which will appear in the JAMA in a couple of weeks now? It was the topic of our last e-chat last week, and it appeared so please comment,
Yeah, I saw the e-chat, and I was very happy of these results, because it showed that the intubation procedure is very tricky, very difficult, and that we have a lot of things to do. And I think the main message was that one patient over two is going to have a low blood pressure after intubation. So that's why I think it's now the area of improvement added to the usual tools that we studied to decrease hypoxemia. So
and so this was an observational study of 3,000 patients from all over the world, but it appeared that between 15 and 20% of patients had a video laryngoscopy in place for the endotracheal intubation procedure. So my question is, before we go on, in Montpellier, how many patients would have the video laryngoscopy? Is it a systematic type of approach?
Yeah, so in our department, in Montpellier, in the department of Professor Jabert, all the patients had video laryngoscopy now for intubation. And it really changed our daily life in the units, especially in intensive care units, because we are not afraid anymore of any intubation, because the rate of difficult intubation is very, very low now. So we experience less desaturation, less hypoxemia, and less complication as cardiac arrest, who are strongly to no intubation.
Let's leave the rest for the discussion, and Professor Samir Jabert will be there. He will be speaking in just a moment. But from the same department, we have Yassir Arab, who also contributed to the latest issue of ICU Management and Practice. Perhaps now we will move more on ultrasound. Yassir, is it correct?
Thank you very much, Professor Vincent, for this invitation. I'm very honored to participate in this DigiConf. I'm Dr. Arab Yassir. I'm working in the anesthesia and critical care team in the Professor Jabert department. And as you said, I will focus today on the novelties and upcomings in the field of lung and diaphragm ultrasound. Let's talk about lung ultrasound. As you know, its use has been described for monitoring the severity of lung injury in mechanically ventilated patients, but it must be said that the daily use of this lung ultrasound is still not very widespread, apart from pleural effusions and pneumothorax, probably because of the idea that interpreting artifacts makes it difficult to use in everyday practice. So now, with the massive inflow of COVID patients, the difficult access to CT scans, and the growing risk of intra-hospital transmission of the virus, lung ultrasound has become more democratized. First, in the emergency ward, the lung ultrasound score allows the triage of COVID-19 patients without strong clinical severity criteria, but who may require hospitalization because they are at risk to develop a severe form. For example, a lung ultrasound score under 5 is very associated with a low risk of severe pneumonia with COVID-19. Beyond clinical studies, we actually see now in our emergency department that the lung ultrasound score is used to decide where to refer mild symptomatic patients. In spontaneously breathing patients, the worsening of this low score over time may help for the decision of intubation. Indeed, the improvement or the worsening of this lung ultrasound score may precede the change in clinical status. And finally, in mechanically ventilated patients, ultrasound allows daily monitoring of lung injuries more accurately than chest X-rays, and thus saving the need of CT scans. Let's talk now about diaphragm ultrasound. It's usually used as a tool for prediction of extubation success. Other uses, like daily monitoring of trophicity or titration of ventilatory support, are still scarce in clinical practice. But the current pandemic promotes the use of these simple tools. Let's focus on intubation. We all face the difficulty of the good timing for intubation. Do not delay, do not rush, mainly because of the new famous happy hypoxemia. It seems that COVID-19 patients now can develop patient self-inflicted lung injury, even when they are still spontaneously breathing and without any sign of major struggle. The assessment of inspiratory effort in spontaneously breathing patients may be difficult without the complex monitoring such as esophageal pressure, for example. The thickening fraction of the diaphragm may help non-invasively at the bedside by detecting an increase in the generating effort, increase of thickening fraction, or even by detecting the beginning of exhaustion, like decrease in thickening fraction. And for example, this decrease has been associated with CPAP failure in COVID-19 patients. Something new about diaphragm injuries in COVID-19 is this study published by Ottenheim and colleagues that provides evidence of ACE2 expression in the human diaphragm and a viral infiltration in muscle fibers in the diaphragm. The authors reported increased expression of genes involved in fibrosis and also an histological evidence for the development of fibrosis in the diaphragm. This phenotype was distinctly different from that of control ICU patients. Why I'm talking about that? This is in line with the now known concept of diaphragmatic myotrauma. This concept states that different types of diaphragm insults may result in different types of diaphragm injuries. So to demonstrate that, we now need qualitative analysis of the diaphragm, which is not easy to perform at the bedside. And the most promising technique, and I will finish with that, is ultrasound shear wave elastography. Simply stated, the elastography is a measurement of the stiffness of the tissue using a quantitative parameter, which is called the shear modulus. A higher shear modulus value corresponds to higher tissue stiffness. Its feasibility in ICU has been demonstrated now in a pilot study published in Critical Care in 2020. And at this time, this is still unpublished data, but shear wave elastography seems to confirm this myotrauma concept with increase in diaphragm thickness associated with a decrease in stiffness. That may be a proof of inflammatory damage as demonstrated in histological samples before. The atrophy, so the decrease in thickness, is associated in our study with an increase in stiffness, and that may be a proof of the fibrosing damage to the muscle, similar to that already described for the hemiplegic side of a patient with a stroke, for example. I will finish with that, and maybe I keep the rest for the discussion, if you're okay, Professor Vincent.
Yeah, how do you explain that it's somewhat typical of COVID-19 to have these fibrotic lesions? Did you say it's quite specific?
Maybe, we don't know for now, but the study by Ottenheim compared COVID-19 diaphragm patients and non-COVID-19 ICU diaphragm patients. And they find two different phenotypes with more fibrosis in the COVID-19 diaphragm compared with similar mechanically ventilated ICU patients. That's all we know for now. I can't say more, but maybe we will have more information in the coming weeks.
And we will discuss it further in the discussion period. Thank you very much. That's very interesting indeed. So now we will move to Vitaly Herasevich from the US. I think we'll speak about telemedicine, won't we, Vitaly?
Yeah. Hello, everyone, and thank you for invitation to be part of this panel. I'm Vitaly Hirasevich. I'm professor of anesthesiology and medicine from Mayo Clinic. By accent, probably you can figure out it's not Minnesota accent. I received my medical degree and PhD in Belarus, but for past 16 winters, I'm here in Minnesota. I'm going to talk a little bit about technology and how pandemic change perception of technology. Probably good analogy would be transformation of the transportation 100 years ago when horses rules world, everybody ride horse. And in 20 years, that's complete transformation happened. There are like automobiles and so, and completely change how all industry works, how people travel the world, and so and so and so. In a part of the technology, we have telemedicine for past 20 years, and it's pretty the same over these 20 years, stayed the same. We have cameras, we have some sort of electronic medical record and connection. But if you look for the change of the technology overall in our world, there are a lot of transformation happen. We got Wi-Fi 20 years ago, that was no Wi-Fi. We got smartphones, which like 15 years ago, nobody talked about it. And many other technologies. Nobody talked about artificial intelligence, which actually was available, but computers, they were not powerful enough to run all this technology. And this is over past 20 years, tele-ICU was more like evolution rather revolution. What happened in 2020 when all this lockdown become in place, there are new way to deliver care needed. At Mayo, that was in matter of the day in outpatient setting, changes was happen. There increased 2,000% in telemedicine consultation happen in a matter of the week or so. But what we can do about tele-ICU with this progress or rapid transformation, that's actually give opportunity to rethink and how technology could be applied to typical telemedicine program. And in past and in current, that's actually telelink on the top of the systems, EMR system. But we have in place mobile technology. For example, Department of Defense, DARPA, they work on some system which bring any participate critical care physician on the mobile platform to do consultation for this rapid floor deployed in a auditorium, in a sport halls, and so and so and so. The future of the telemedicine would be more as a coordination center, which would be cockpit, and number of the technologies run on the top of this data links or so. We have sensors, we have computer vision, which can watch patient 24/7 and detect deterioration. We have audio, auscultation type of the sounds and analysis for the technology, and also mobile. I mean, most of us now, they're in different location. You don't stick with some location to be able to connect the world. That's a transformation happen right now, and new generation of this technology apply this, very quickly.
Would you say that COVID-19 has catalyzed a process and maybe helped to speed it up? Or was it something that was underway and COVID-19 does not influence it too much?
Absolutely, that was trigger to enable this technology. Technology were available, but nobody want to change anything what works. But in this situation, that will become trigger to try new way.
Well, it was already applied in a number of places, but but I think with COVID-19, there was really a push to make much progress. Yeah. Okay, we will return to that. Thank you very much. But let's move to to Professor Andrej Mikkelsen from Germany. I think we'll speak more about prioritization, especially during COVID-19. Andrej?
Thank you very much, Jean-Louis, for the invitation. Good afternoon. I'm very happy to speak about prioritization in the field of COVID-19. Actually, this is not proactive, but it has to be reactive because we've all gone through that pandemic caused by a virus. And due to that pandemic, some things became scarce. There was either apparatus or it was personnel. So obviously, the decisions needed to be made to prioritize those scarce resources. And that, on the one hand, seems to be a fairly simple medical task. However, it's now become a, if you will, social cultural challenge, because as already Virchow had said, a pandemic is a social phenomenon that has some medical aspects. So in terms of that prioritization progress, we have faced criticism from many parts. We faced criticism from people, especially governments, who think that by controlling their people and controlling the virus, they can solve the problem. The problem with that is that you cannot control people's for a long time, and you can certainly not control the virus from the beginning. There's also been conspiracy theories, which I'm not going to discuss any further because to my personal understanding, they're all wrong. But there's also very important critical ethical reasoning that perhaps when you do prioritization, you have to also think about inequity in healthcare and perhaps have to be somewhat more lenient to subpopulations that structurally have had a less good healthcare. The problem with that is that the question arises whether a physician on the micro level having to make a prioritization for urgent intensive care has to take that into account. So some people think that in the end we need to call the law. Well, that is a fallacy because the law will not make decisions for individual patients. And as to sum it up quickly and leaving the rest to the discussion, we still think, my co-author, Dr. Rustinova from Prague and myself, that in the end, it is still left to the physicians and the nurses and the allied health professionals to make prioritizations decisions, which of course have to be based on the best medical evidence as well as on transparent and fair and consistent decision rules. Thank you, Jean-Louis.
Well, thank you very much. And indeed, you reminded us very adequately, appropriately, that it's not only a matter of beds. People often refer to the number of ICU beds, which is limited, but it's not just bed, it's also material and personnel.
Yeah.
In Brussels, we would have the opportunity to open the military hospital, which is almost empty here. But, you know, if you have no personnel who is used to deal with these patients, and if you do not have enough respirators or ECMO, etc., it's or CPAP system even, it's of very limited value. And it's very good that you emphasize that law will not really make it work, and we need to apply, of course, important principles, but organization is very important, and experience can significantly help. Yeah, I have enjoyed your input, Andrej. Thank you very much.
Thank you.
And so we already heard Audrey and Yassir from Montpellier, but now we will hear the boss, Samir Jaber, head of the Department of Anesthesia and Intensive Care in Montpellier. So what are the lessons from 2020 according to you, my good friend?
Thank you very much, Jean-Louis. Good afternoon, everybody. This year was a very hard year for us, for everybody. I want just to give you maybe three major messages for me. First of all, for the COVID-19, I think that in 1 year, we improve to use probably more and more non-invasive ventilation support. This is in 1 year, we changed totally our practice. That in the first wave, all the physicians probably tried to forbidden the use of oxygenotherapy, high flow oxygenotherapy, because the high flow on the dispersion, the aerosol therapy. And the second is the non-invasive positive ventilation. As you know, the non-invasive ventilation, everybody afraid initially from the dispersion of the virus in the room. So this was forbidden in the first period of the COVID-19, and then we observed a lot of intubated patients very early. We didn't know what is the hypoxemic sealant. This is very tricky for us. And then a lot of patients have been early intubated. We don't know if this patient did benefit or not from non-invasive ventilation, but we know that tracheal intubation in a very severe hypoxemic patient without reserve could be at risk, as said by Audrey. So the second step was how to improve the intubation of this patient. And Audrey highlighted about all the mechanisms that we could improve this procedure, because we know that this procedure is related with high life-threatening complication, as showed by this by the last study of the JAMA. The study of the JAMA is exactly the same study that we performed in France. We did not participate because we have at the same times a competitive study, and that's what is going on. And then we reported several tips that could improve. And I think that one of the major tips, as presented clearly by Audrey, is probably the use of the video laryngoscope. Audrey clearly made several papers showing that we could improve probably the procedure. I did not detail the results, but you know it's probably for us today is the first line therapy for intubation, and both in OR, in operating room, and in intensive care unit. But we need to be skilled with this technique, because the first randomized control trial showed a neutral results. That means no significant difference between the laryngoscope and the classical Macintosh laryngoscope versus the video laryngoscope. This is explained very easily because the operators were not skilled in this technique, and this is easy. We show.
Okay.
And
yeah.
The last thing that I want to finish is the first thing is about the obese patient. As you know, COVID-19 probably affect more and more obese patients. We know now how we have a lot of data about this, and it's update for us the way to manage the ventilation of obese. And my three main message about this: please use similar tidal volume according the height and not the weight. This is very important. And second, please consider higher PEEP level in comparison to non-obese patient.
Yeah.
And please consider probably for majority of the patient to tolerate a plateau pressure more than 30 or 35 centimeters of water. This is very important because today we called two centers called us because said, oh, we need your help for an ECMO for 2 patients. And I asked them how the situation of the patient. Said, oh, it's an obese with an BMI of 55. The PF ratio was 70. And I asked them, how you ventilate this patient? Oh, I have 16 centimeters of water PEEP, 500 milliliters, but I'm very afraid because the plateau pressure is around 23, 24. And this is probably change our paradigm to this, and this I want to take this message. Thank you.
Yeah, sure. Yeah. But indeed, that's interesting, and we hope that we will hear more about what we learned from the respiratory management of these patients. But indeed, and it's a question which is raised by an attendee. What can we say about the right time to intubate the trachea? And I'd like to focus a little bit on the time course. Perhaps Ashish can comment on that, because he mentioned that we could look at different variables and see how they can evolve. And then Vitaly could also intervene when he speaks about telemedicine. Could we perhaps advise from the distance, possibly? So Ashish, what do you think? The right time to intubate the trachea?
So I'm guessing the attendee wants to know, for a COVID-19 patient, what is the right time to intubate the trachea?
Yeah, but we could extend the question, because it's a question that we often have when I teach my students. I don't know what to say. I say, look at the patient, measure this and that and that. But at the end, there is no strict rule when to intubate the patient. Obviously, we need to integrate a number of variables there. Do you agree?
Right. So I absolutely agree. I think a big problem in standard teaching is that we focus only on looking at the respiratory mechanics when we decide to intubate. I often tell my trainees that the heart and lungs live really close together, so don't try and separate them. So if your patient is hemodynamically unstable or going to be unstable, then there is no reason why you should not be looking at intubation, even though the respiratory mechanics may look okay at that point in time. That patient is going to tire out pretty quickly in the next 15, 20 minutes, a half an hour. So the first important point is to look at the heart and lungs as a single unit. So if your patient's, in my opinion, if your patient is showing extreme variability in heart rate, extreme variability in blood pressure, and extreme variability in the work of breathing, then all of it needs to be taken as a single unit. Now, I don't have a great formal prediction index for intubation right now, but I think the second point there is we need to do a better job with how we collect data in ICUs. And I think that's a whole discussion in Europe and the United States these days is data in the ICU. Our patients give us millions of data points every day. Every breath our patient takes without the ventilator or with the ventilator, they're giving us a data point. But at least in the US, we are not able to capture all those data points. And because we're not able to capture all those data points, we don't have a great formalized prediction index for a thing like intubation. We just have to go by, Dr. Khanna feels this patient needs intubation. Let's go ahead and intubate. Or Dr. So-and-so might come along and say, no, this patient does not need intubation. But yeah, that is my best answer right now. We need to do a better job at collecting data and more granular data.
Thank you. So Vitaly, can I call you and ask you to look at my patient with your camera to help me?
Actually, that's in this case, it was not camera. Like I say, our experience in very first day of pandemics, you really don't know how much patient need attention. And what we did, we actually did very simple surveillance system. And again, everybody need to understand, no technology can replace human inaccuracy or at least definite decision making. But surveillance system, let's call it like a fraud detection in a banking system, and something suspicious going on, it's very easy to build. In that situation, we built very simple surveillance system institutional-wide. We look for the COVID test, if it's pending or positive, and then we look for respiratory rate, if that become more than 30, and another parameter was increase in oxygen demand. If patients switch from one mode of the ventilation to higher, like from room air to nasal cannula or something higher, that's trigger alert. And again, that's not definite alert to do intubation or so, but that's actually sent clinician to bedside to check patient and see what's going on. I mean, this simple formula works quite well, and no cameras.
Well, I still believe that having someone like Samir Jaber watching the patient with me, come on, Samir, what do you think? I think it could be helpful because we could benefit from his expertise. Would you agree, Samir, to join?
Yes, absolutely agree. This is, I think I share this experience that presented by Vitaly. Agree with you, absolutely.
Now, Andrej, my patient is 90 years old with COVID, and the patient is on CPAP and it doesn't do well, but I would prefer not to intubate the patient because that may be too much. What should I do? Should I still do a trial for a couple of days and then discontinue my efforts if it doesn't work? Or should I continue as it is? Could you give us a little advice on this difficult situation?
Thanks, Jean-Louis. I think, first of all, you need to talk to the patient, if you can still talk to the patient.
The patient. The patient.
Okay, if the patient cannot, yeah, I understand. Then hopefully someone in the course of the treatment before that would have found out what his wish or will were.
Good.
And who would represent the patient legally.
Good.
Because one thing is the indication that I strongly hold that is our job, and the other pillar is the patient's wish. And if we are in a gray zone, which means we're not quite sure about the prognosis and we're not so sure about what the patient wants, then I think a time-limited trial is always advisable, which means that we have to set a clear timeline and we need to set parameters that we judge on whether the trial is successful or not. And I'm certain you're going to go on to say, now comes the 20-year-old lady with 2 children. She needs the same ventilator. What do we do?
Yeah.
Yeah, exactly, Jean-Louis. Knowing you, I tell you that is one of the most difficult questions because legally, at least in Germany, it's a very tricky question to take something away from someone already using it because someone else might have the better odds with the same ventilator or personnel. And I think I do not have, and I don't think anyone really has a flow chart for that.
Well, that's what we do, and I was pleased to read in this excellent paper on ethical aspects on COVID in the New England Journal of Medicine that the principle of first come, first served should not be applied in all cases, and I fully support that. Otherwise, like in the north of Italy, in many cases, the ICU is full. What can I do? The ICU is... No. You need to go back. If the ICU is full, if you need the material for this patient, you may have to give up in the other patient.
Yeah.
But that's an ethical discussion that may lead us a bit far away.
I agree.
Yassir, would ECHO help you to decide when to intubate a patient and when you can wait, or it's not really a good indication above the clinical evaluation? We cannot hear you, huh? You're on mute.
Thank you for the question, Professor Vincent. Yes, for me, it's personal advice. It's not a recommendation. Ultrasound may help. Diaphragm ultrasound may help, not lung ultrasound. Why? Because, as I said, you can have an excessive inspiratory effort with patients without any clinical sign of distress. So when we take a patient in our ICU and because he's hypoxic, so he have high flow nasal oxygen, he may stay with quiet breathing, maybe with the classic 25, 30 respiratory rate, but he's fine with 93% of saturation. So what we try to do is to monitor the thickening fraction of the diaphragm. And I think that's the best parameter, better than the excursion course of the diaphragm. And when we have a significant change, so more than 10 or 50% of the thickening fraction, otherwise an increase or a decrease, the increase seems to be related with an new excessive effort, and the decrease is related to a sort of exhausting of the patient. So we consider with more attention at the intubation. You know, it's not the only parameter we use, but we cannot wait to have more hypoxic patients if we have this parameter with ultrasound. If the patient, of course, if he became more hypoxic, we're gonna intubating him. Otherwise, the technique fraction is the same or not. But it's a parameter we can add to the clinical evaluation of the physician.
Okay. Now, if we had to ask you what you missed the most during the COVID-19 pandemics in your ICU, what kind of material, would monitoring system or anything else, treatment, whatever, that you would have liked to have? Audrey indicated video laryngoscopy for everybody, okay? But Audrey, do you have something else in mind? And what about the others? Let's say you have a manufacturer listening to us and they feel they have a lot of money to place in COVID-19 patients, but they hesitate between several options. What would you recommend? Audrey, would you start?
Yes, of course. Yes, so regarding the device for intubation, I think we need a video laryngoscope with optimization of screen because to protect caregivers the most, it could be useful to have a separate screen, but also something little to enter in when the opening of mouth is limited. So something with separate screen, but not too strong neither. So maybe the manufacturer can improve the device of intubation, including video laryngoscope, to be more available at bedside and also more available in other units. So something we can move very easy. You can have in your suite or in a simple box, and also with a deported screen. So it is challenging to have both in the same device.
Okay, Ashish, please.
Yeah, so I have a slightly different perspective on this. I think within the ICU, generally ICUs all over the world have all sorts of equipment and monitoring and everything else. I think with COVID especially, something I really missed initially, especially in the United States, was patients who were being sent home from the emergency room because they were okay, and they would come back 4 days later on the verge of dying, right?
Yeah.
So,
yeah.
And not just that, we were so tight with our ICUs that we had to fight every day to see what patient needs ICU and what patient will be okay on the floor. And a big gap, again, is monitoring. So if any device manufacturers are listening to me right now, we need to do a better job with portable multi-parameter patient monitoring that is user-friendly and that patients can take home and not be distracted with the alarms and the data. The data should flow to a hospital, to a physician who's watching the data. But we need more surveillance for our patients outside the ICU, especially COVID patients, because they go from normal to abnormal and they don't know that they are abnormal.
Yeah, interesting. Vitaly, would you go along the same line?
Yeah, absolutely. And it's difficult to comment on the resource strain. Yeah, we are in a different, different environment, and may obviously would be an outlier in this regard. But I absolutely agree with Ashish. What we need to have more data for surveillance purpose. I mean, if there are no data, how you can detect anything, you know? That just need to have portable and medical home type of the devices.
Is it something that we miss very much from the COVID experience?
It's actually enable understanding and that just enable this use case. And if people are still are before that did not understand the importance of that after this first wave of the COVID is because become very obvious what this device is needed.
Yeah, what kind of, okay, we can continue with the material, or you may wish to speak about the additional data we should have. Andrej, would you like to comment on these two aspects?
Yes, thank you.
Either of these two aspects.
Yeah, thank you. You asked before if we were things that we were missing.
Yeah, right.
Of course, the one thing would be the drug, whatever the drug is. However, it seems to be very difficult, even with a lot of money. I go a different route. I would say what we miss is an understanding of ethical principles and reasoning. And what we miss most of all is common sense. Those very sick will not profit from all our nice technology. And those too good don't have to be on the ICU. But that is physicians and nurses thinking about it.
Yeah, someone asked what we think about ivermectin. I can say that from the evidence we have, we cannot conclude. Personally, I think that the chances to see it as an active drug are relatively limited, but we need to have more data. Let's hope we will not repeat the story of the hydroxychloroquine because it's an easy drug. Wow, why don't you give it? That may not be the right type of answer. Samir, I see you smiling. Do you agree or disagree? We cannot hear you. You are on mute.
No, I agree because we have a similar discussion this morning about the optimal drug. And in the reality, we don't have strong data today to select one drug to another drug for sedation or for analgesia. And now we believe, I think we should consider also the halogene drug in ICU. We have some encouraging data about this.
You mean the inhaled anesthetic agents?
Inhalated anesthesia. Yes, inhalated anesthetic drug, like mainly Sevoran in Montpellier, Sevoran and Isoflura. The both that we use.
Yeah.
Now we have in the market some available new machines that delivered, like in the machine in the operating room, available for ICU with safety use and with monitoring of exhaled drugs, exhaled halogene. And this
okay.
This will be for us sometime when we are limited to have, I don't know, propofol or other drug in some situation of crisis. This should be considered for the future.
Yeah, now there are a number of agents that could be considered and that may be slightly effective in critically ill patients in addition to dexamethasone, of course, and perhaps tocilizumab in some patients. But it would take a long time to discuss all these therapeutic options, and clearly there is no miraculous option. That's for sure. Now, did we do the proper clinical trials? Someone asks us if we could, do what could we improve with our clinical trials? Who would like to comment on that? I think we could have done better with our clinical trials, but I would like the others to comment on that. Vitaly.
Yeah, that's actually, I would use this very well-known paper on the parachute trial.
Yeah.
You don't need to jump parachute and do randomized trial to get obvious information what parachute is useful. And there are probably less known paper when people did parachute trial. Very strict protocol. Somebody jump from the plane with parachute, without parachute, but plane was on the ground. And there is strictly follow protocol. You can find this in PubMed or so.
Can still be dangerous to jump from the plane on the ground.
Yes.
Okay.
Means, that means that's obviously there are clinical trials not needed for different questions, and that's a very, very good question for discussion.
Yeah, but in COVID-19, it's difficult not to do prospective randomized control trials. It's a single disease. You cannot say that there is such a heterogeneity that we will never find out that something is effective. That's not true for COVID-19. So I think we could have started the randomized controlled trials more effectively earlier. We were not very well organized. Ashish, what do you think?
Yeah, I kind of agree. I also feel that there was sort of a panic mode last year when this happened, and people wanted to quickly publish and get the data out. And, you know, we all know what happened to hydroxychloroquine data comes out. I am more worried about not just doing the trials, about how the world interprets the results of the trials. Because I have seen time and time again with COVID, you know, results come out in the New England Journal or JAMA or one of the reputed journals, and people just go for that drug or that therapy across all of their patients without looking at the actual trial. Remdesivir is a prime example. When it came out, people just went all over the place with remdesivir. And we know that remdesivir is trying to act against viral replication. We're trying to give it on patients who are 2 weeks into the course of their disease.
Yeah.
The virus is probably not actively replicating at that time. And I think that's prime example. You know, we see the paper and then we run to our patients and we get the drug approved and everyone's using it then. So I think we have to be careful on how we use the data, not just read the paper and go for it.
Yeah, sure. I'm looking at the clock, and I think we have addressed quite a number of questions asked by the audience. Perhaps two last questions. One question is, what kind of new data you would like to see from COVID-19? What is missing? We had these discussions on is it RDS, the same one as the others, or is it different? We spoke about when to intubate the trachea. You know, what kind of data are you looking for most anxiously? Who would like to address the question? Very briefly.
Yeah, I just comment, you know, it's something would probably not happen. Yeah, data from pre-hospital environment, how this disease developed before admission, because patient when get to hospital, they pretty same stage.
Yeah. Okay, Samia. Andrej. Audrey.
Yes, I would like more individualize the data according to patient and to evolution of the disease, because I think at the beginning of the disease it's not the same that 2 weeks after. So maybe more focus on the timing of drugs or other therapeutics according to the stage of the disease.
Defining phenotypes a bit better.
Yeah.
And that's very important. We just spoke about the treatment that may be different. You may give antibodies early, but not in the ICU. Specific antibodies, monoclonal antibodies, have not been found very effective in the ICU. Yassir, any other comment about that? What kind of data you would like to see?
I agree with Audrey, maybe more personalized data. I have to say I was very disappointed to not see more studies interest on the respiratory drive of patients. Today I just made again the bibliography, and there is 2 studies to date with respiratory drive specifically in COVID-19 patients, and everyone is talking in the Congress between colleagues about this high respiratory drive we have before intubation. And when we try to wake up the patient, so we have patients without a big hypoxemia, but with a high respiratory drive, and we have to, again, sedate him and put him under controlled ventilation. So I think there is some studies with the virus in the lung, the virus now in the diaphragm, but it's still scarce, and I think it's something we have to learn more about.
Last minute. Each of you, what is the one single thing we could have done better? If we had to do it again, there is one thing that we would do better. Yes,
I'll start very quickly. Again, slightly different perspective. Take care of family members and take care of providers. those are the people who have sort of had the secondary hit from all of this. Family members have been deprived of coming into ICUs. I really feel we should have done a better job with that. No one deserves to die alone. And our
very
ICU
good point.
ICU nurses.
Same point. Thank you.
Audrey.
Find the good timing for intubation.
Yeah, could you be more precise, individualized, or earlier or later?
The good, not too early and not too late. And
the right time. Okay, yeah. Yassir?
A better managing of the human people with the caregivers, and maybe stop the surgical activities before to have more nurse in the critical care.
Organization.
Yeah.
Vitaly?
Probably more consistent public health message and strategy. But again, that's, you cannot do this without learning.
Yeah, but let's stay in the ICU now. And Samir, what do you think?
To avoid futility of critical care in some patient, I think, because in my unit, I have a lot of young doctors, and the young doctors never stopped the care. And when you are more and more and more old, you have less and less aggressive care, in contrary. This is very active staff every morning with my young doctors, my old doctors, and it's very difficult to have now no controversy that are about the independent risk factor of mortality. This is very hard, really hard today.
Very good. We could continue for a long time, but I'm afraid our time is up. So I will thank you very, very much and thank our attendees, and we will certainly repeat this experience in the future. It was very nice having you on this artificial podium. So take care. Bye-bye.
Thank you for watching 20 Lessons from 2020, the DigiConf in line with the ICU Management and Practice Journal. Issue 2 of ICU Management and Practice will highlight issues related to well-being in the ICU. The publishing date is 19th of April and the DigiConf will be on the 4th of May. This DigiConf was brought to you by MindBite Communications, streaming healthcare.